You know, um, usually when we talk about a medical diagnosis, there's this expectation of precision. I mean, like engineering.
Yeah, absolutely. It's a very mechanical view.
Right, you break your arm, the x-ray shows that jagged white line,
Hmm.
and the doctor just points to the film and says, there it is.
Exactly. It's a structural problem with a very structural, observable solution. The bone is broken, so, well, we set the bone.
And it's comforting. We like things to be visible, to be, categorized neatly into boxes where the cause and the effect are just sitting right there on the table in front of us.
Which makes sense. It's how we navigate most of medicine.
Yeah, but then you step into the world of neurodevelopment, of mental health. And suddenly that x-ray machine is, well, honestly, it's pretty useless. We're looking at a diagnostic landscape that is just murky,
Highly murky.
especially with conditions that essentially trap the mind in its own loops. Which is why today we were doing a deep dive into a really fascinating Substack article from SpiralSeekr. And it's actively challenging basically everything we thought we knew about treating obsessive-compulsive disorder.
Yeah, OCD. And the central argument in this material is, frankly, a complete paradigm shift. Because for decades, the standard treatment for OCD has essentially been a daily pill, right?
Right, the SSRIs.
Exactly. A daily pill aimed at tweaking a single specific brain chemical with the hope that it somehow smooths out the severe distress patients are experiencing.
And the setup here is critical for you to understand. What if that entire approach is fundamentally flawed? And what if we've been trying to fix a structural problem with a crude chemical wash?
It's a great question, and the core revelation we are exploring today is a radical shift away from what the author calls chronic suppression, using standard antidepressants and moving toward a model of acute disruption.
Acute disruption.
Yeah.
And that disruption comes from a historically profound source, which is classical psychedelics.
Right. Compounds like psilocybin and LSD, but utilized not as daily maintenance medications to just dull the pain, but as acute catalysts for deep neurological reorganization.
So look, whether you are someone who has dealt with OCD, or maybe you have a loved one who struggles with it, or whether you are just sitting there right now fascinated by neuroplasticity and the bleeding edge of mental health, this deep dive is going to completely reframe how you think about the human brain's ability to heal itself.
It really changes the conversation from managing a lifelong condition to actively remodeling the architecture of the mind itself.
Okay, let's unpack this. Because to really understand the intervention, we have to truly understand the problem first.
Right, the baseline.
Yeah. For a lot of people, OCD is still, unfortunately, misunderstood as just being really neat or wanting your desk perfectly organized.
Which is such a massive misconception.
It's a severe psychiatric condition. It's characterized by these deeply intrusive, unwanted thoughts, which are the obsessions, and the repetitive, agonizing behaviors performed to neutralize them, the compulsions.
It's incredibly debilitating.
Right. But I want to move past just the behavioral symptoms. Let's look at the brain's wiring. What is actually happening neurologically when someone is trapped in one of these episodes?
So the primary neurochemical model for OCD points to a very specific set of neural pathways. It's called the cortico-striato-thalamo-cortical circuit.
That is quite the mouthful.
It is. Neuroscientists usually just abbreviate it to the CSTC circuit.
The CSTC circuit. Okay, it sounds a bit like a municipal transit system.
Honestly, it essentially functions as one. It's a communication loop connecting different regions of the brain. You have the cortex, which is your higher-level thinking center.
Right, the decision maker.
Exactly. Then the striatum, which helps coordinate motivation and physical action. Then you have the thalamus, serving as the brain's main sensory relay station. And then the signal loops all the way back to the cortex.
Got it. So it's a closed loop.
Yeah. And in a neurotypical brain, this circuit regulates executive control, cognitive flexibility, and behavioral inhibition.
So it's the system that tells you, like, you've checked that the stove is off, the task is complete, you can move on to the next thought.
Precisely. It's the physical mechanism that allows you to transition from one action to the next.
Okay, and where does serotonin fit into this?
Yeah.
Because that's all we hear about with mental health.
Right. So a key chemical modulating this entire transit system is serotonin, or 5-HT. Serotonin acts as the regulator. It ensures the signals flow smoothly and at the appropriate volume.
Okay.
But in OCD, according to the source material, this CSTC circuit becomes profoundly hyperactive. The signals get amplified, and that vital task, complete message just never effectively registers.
Wow. So I'm picturing this hyperactive CSTC circuit like a massive traffic roundabout.
I like that analogy.
Yeah, so In a normal brain, cars, which we can think of as thoughts, right, they enter the roundabout, go a quarter of the way around, and then safely take their exit.
Normal traffic flow.
Exactly. But in the OCD brain, it's as if all the exits are suddenly barricaded. The cars just keep circling.
Right, they can't get off.
The thought loops endlessly. Is the door locked? Check the door. Is the door locked? Check the door. It creates this incredibly rigid, repetitive cognitive pattern because the physical architecture of the roundabout is actively trapping the traffic.
And that structural rigidity you're describing with the roundabout is exactly what shows up on brain scans.
Wait, really? You can see it physically?
Oh, yeah. The neural pathways involved in that looping thought become deeply entrenched. It's not just a passing worry, it is a physical, neurological gridlock.
Wow. Well, this brings us to the great frustration of modern psychiatry, doesn't it? If serotonin is the traffic cop supposed to be directing cars out of this roundabout, why don't our current serotonin-boosting drugs solve the problem?
It's the million-dollar question. The current first-line pharmacological intervention for OCD consists of selective serotonin reuptake inhibitors, or SSRIs.
Right. Drugs like fluoxetine or sertraline.
Exactly. To understand why they fall short, we have to look at their specific mechanism of action. SSRIs operate by binding to something called the serotonin transporter, or SERT.
Which acts kind of like a vacuum cleaner in the brain, right?
Yeah, that's a good way to put it. When neurons communicate, they release serotonin into the tiny gap between them, which is called the synaptic cleft.
Okay.
Normally, that SERT vacuum cleaner sucks the excess serotonin back up into the cell to be recycled. What SSRIs do is they block that vacuum.
So they plug it up.
Right. By inhibiting the reuptake, they force whatever serotonin is already there to linger in the synaptic cleft, increasing its overall extracellular concentration.
Which, I mean, the logic makes sense on paper. You have a roundabout problem, you assume the traffic cop is asleep, so you just flood the intersection with more traffic cops.
That was the prevailing theory for a long time.
But the data from the SpiralSeekr article highlights a deeply flawed reality here. The American Psychiatric Association's own treatment guidelines show that approximately 40% to 60% of OCD patients exhibit an inadequate response to SSRIs.
It's staggering.
Up to 60% are getting only partial relief, or just absolutely no relief at all.
And we need to talk about what partial relief actually means in the context of OCD. It comes with massive caveats.
How so?
Treating OCD is not like treating major depressive disorder. To even nudge the needle on severe obsessions, patients require significantly higher daily dosages of these SSRIs than a depression patient would.
Wow. And let's talk about the latency period, too, because the source explicitly points out that patients have to wait an agonizing 8 to 12 weeks just to observe initial benefits.
Yeah, 2 to 3 months of waiting.
I want to put that into perspective for you listening. Imagine being trapped in a terrifying, looping thought where you genuinely believe you are going to accidentally harm someone you love.
Which is a common OCD theme.
Right. And the medical protocol is to take a massive dose of pills every day and check back in 3 months to see if the volume turned down by maybe 20%.
It is a devastating timeline for someone in acute psychological distress.
And we can't ignore the physical toll either. The article lists the severe adverse effects of this chronic high-dose administration. We're talking about persistent sexual dysfunction, severe gastrointestinal distress, significant weight gain, and emotional blunting.
That last one is huge. Patients often describe emotional blunting as feeling like they've been wrapped in bubble wrap.
Bubble wrap, wow.
Yeah. The debilitating lows aren't as low, sure, but the capacity for joy, the highs, are completely gone.
They're basically trading one form of profound suffering for another, often just to achieve a marginal reduction in their daily compulsion.
Exactly.
I have a major point of pushback on this entire methodology, though. If OCD is ultimately a structural issue, like a rigid neural circuit, an entrenched roundabout with blocked exits, why have we spent decades just flooding the brain's synaptic clefts with serotonin?
Right.
We are essentially pouring more and more water into the roundabout, hoping it somehow magically changes the physical concrete of the barricades.
Yeah.
It just feels logically disconnected from the biological reality of the disorder.
What's fascinating here is that the psychiatric community has been wrestling with this exact contradiction. As SpiralSeekr points out, the delayed onset and the high rate of partial response strongly indicate that merely elevating synaptic serotonin is wildly insufficient.
So the whole mechanism is flawed.
SSRIs operate on what the author calls a chronic suppression model.
Chronic suppression.
Right. They require continuous daily administration just to mask the symptoms. They elevate the baseline serotonin to sort of muffle the alarm bells, but they rarely resolve the underlying circuit dysfunction.
So the roundabout is still broken.
The roundabout is still completely broken. The traffic cops are just shouting louder over the noise of the circling cars. And if a patient stops taking the pill, the suppression lifts and the looping behavior immediately returns.
Because the physical structure of the brain never actually changed. So the medical field is hitting a wall here. Chronic suppression is failing up to 60% of patients and causing severe side effects for everyone else. We don't need a daily maintenance crew to manage the traffic. We need a demolition and reconstruction crew.
We need an intervention that interacts with the serotonergic system in a fundamentally different way.
Here's where it gets really interesting. Enter the psychedelic intervention paradigm.
Yes.
The article pivots sharply from SSRIs to classical psychedelics, specifically psilocybin, which is the active compound in magic mushrooms, and LSD.
Which is quite the leap from standard daily pills.
Right. And these compounds also interact with serotonin, but they don't do that vacuum blocker trick that SSRIs do.
No, they bypass the serotonin transporter entirely. Instead, classical psychedelics act as direct agonists or partial agonists, specifically binding to the 5-HT2A receptor subtype.
Okay, so instead of adding more natural traffic cops by blocking the vacuum, you're introducing a completely different, highly specialized task force that uses a different set of walkie-talkie frequencies entirely.
I love that, yes. And the clinical outcomes are drastically divergent from standard SSRI administration.
Tell me about the data.
The article highlights a foundational 2006 proof-of-concept study by Moreno and colleagues at the University of Arizona.
Okay, 2006, so this isn't brand new.
No, and this study is a critical piece of the timeline because it really set the stage for the modern psychedelic renaissance we're currently seeing in psychiatry.
I have to play devil's advocate here, though. Treating treatment-resistant OCD is notoriously difficult. Did this study actually show measurable results, or was this just, a theoretical exercise with some marginal improvements?
Oh, the results were highly significant, especially given the demographic they were working with. These were subjects who had exhausted all conventional options.
Oh, the toughest cases.
Exactly. They had suffered from severe chronic OCD for years, failing multiple trials of standard therapies. And the study found that acute administration of psilocybin induced rapid, substantial, and sustained reductions in their OCD symptoms.
Acute is the vital word there, right?
It is the whole point. We are not talking about daily dosing for 12 agonizing weeks. We are talking about singular, distinct clinical sessions.
Wow.
The timeline of relief was rapid. Patients were often seeing a dramatic drop in their symptom severity scores within hours or days of the session.
Hours or days compared to months.
Right. And the symptom reduction wasn't just a slight muffling, it was substantial, and the effects were sustained long after the drug had completely left their system.
So to refine our earlier analogy, if SSRIs are like adding more traffic cops to a broken roundabout every single day just to manage the chaos, psychedelics are like temporarily shutting down the highway entirely, bringing in heavy machinery, bulldozing the concrete blockades, and physically rebuilding the off-ramps.
And that structural rebuild is what allows the trapped traffic to finally exit the loop.
I want to get into the biological nuts and bolts of that rebuild. I mean, what does this acute disruption really mean when we look at the brain under a microscope?
Well, the SpiralSeekr piece breaks down the pharmacological efficacy of psychedelics into 3 distinct pillars.
Okay, what's the first one?
Starting with network disruption. Neuroimaging data shows that when psilocybin binds to that 5-HT2A receptor, it acutely decreases connectivity within something called the default mode network, or DMN.
The DMN, what does that do?
The DMN is essentially the brain's resting state network. It governs self-referential thought. It's highly active when we are ruminating, daydreaming, or, crucially, evaluating threats to our own identity.
So it's the me network.
Exactly.
Why does that specific network being active cause such a problem in OCD?
Because the DMN constantly references the self. In OCD, the DMN becomes overly rigid and tightly coupled with those hyperactive CSTC loops we talked about earlier.
Ah, so they feed into each other.
Right. It creates an endless loop of self-doubt. Did I leave the stove on? If I did, does that mean I'm careless? Am I a bad person?
Oh, wow.
By decreasing connectivity in the DMN, the psychedelic physically disrupts those loops. It temporarily takes the power grid offline.
That makes so much sense.
The obsessive rumination simply cannot sustain itself because the decentralized circuit is no longer feeding it energy.
Okay, so you take the power grid offline, which breaks the immediate cycle. But, the drug leaves the system in a matter of hours. Why wouldn't the brain just eventually revert back to its hyperactive state once the power comes back on?
And that brings us to the second pillar, neuroplasticity. The article notes that psychedelics acutely promote both structural and functional neuroplasticity.
So while the power grid is offline, the physical hardware is actually being upgraded.
Yes.
This is the specific mechanism that really caught my attention in the source, because it specifically mentions increasing dendritic spine density and synaptogenesis.
The actual cellular growth.
Right. To translate the biology for a second, dendrites are like the branches on a neuron that reach out to receive signals from other brain cells. And the spines are the little buds or receiving antennas on those branches.
And synaptogenesis is the creation of entirely new synapses, the actual connection points between neurons.
So the brain is actively growing new biological hardware. It's sprouting new branches and making new connections at an accelerated rate.
It literally forces the brain out of entrenched maladaptive pathways.
Because it is laying down new alternative roads in real time. The roundabout exits aren't just unblocked. Entirely new highways are being constructed, allowing thoughts to bypass the damaged intersections entirely.
It creates a critical window of flexibility. The rigid architecture is softened, allowing for the reorganization of cognitive patterns. You are no longer trapped by the old wiring because you suddenly have functional access to new wiring.
Okay, so we disrupt the old network and we build new neural highways. But even with new highways, if the brain still has a hyperreactive tendency to panic, the OCD could theoretically find its way into the new wiring, right?
That's a very valid point.
So how does the treatment address the underlying anxiety response?
That's the missing puzzle piece, and it comes down to a physiological adaptation called receptor downregulation, which is the third pillar.
Downregulation?
Right. When those classical psychedelics heavily stimulate the 5-HT2A receptors during the acute session, the brain reacts to that intense stimulation.
How does it react?
It recognizes the massive influx of activity, and it responds by internalizing those receptors. It physically pulls them back from the surface of the cell, down-regulating their availability.
Oh, kind of like squinting your eyes when you step out into incredibly bright sunlight. Your body actively reduces its sensitivity to the intense stimulus.
That is a perfect analogy, yes.
But why does less receptor availability actually translate to fewer OCD symptoms?
Because those specific 5-HT2A receptors are the primary facilitators of those hyper-anxious looping signals.
Yeah.
By physically reducing the sheer number of those receptors on the surface of the cell, you are fundamentally turning down the volume knob on the brain's ability to panic. The system becomes less reactive to the obsessive triggers overall.
Wow.
And research shows this rapid downregulation directly correlates with the sustained symptom relief patients experience long after the drug has cleared their system.
If we connect this to the bigger picture, the contrast between these two paradigms is just staggering.
It really is a tale of two entirely different philosophies of medicine.
Right.
The SSRI approach requires daily dosing to maintain an elevated chemical baseline. It's a lifelong commitment to managing a symptom, constantly fighting against the brain's existing rigid architecture.
Whereas the psychedelic approach is administered in discrete, tightly controlled clinical sessions.
Exactly. These compounds act as rapid catalysts. They induce a transient, temporary window of extreme neuroplasticity, allowing us to modify the structural foundation of the disorder itself.
We are curing the concrete rather than just, washing it.
Curing the concrete. I like that.
So what does this all mean for you listening right now? The key takeaway from this SpiralSeekr deep dive isn't just that there might be a new drug pipeline for OCD.
No, it's much bigger than that.
It is a profound, fundamental paradigm shift in how we view the human mind. We are moving away from the depressing idea of chemical imbalances that you simply have to endure and manage with chronic suppression.
And we are moving toward a highly empowering reality.
Exactly. The mental health challenges are often rooted in entrenched neural pathways. And pathways, no matter how deep, no matter how agonizing, can actively be rerouted. The brain retains the ability to structurally reorganize itself.
Which is incredible. And this raises an important question, and it's one I think researchers will be exploring for the next several decades.
What's that?
If a single acute disruption from a psychedelic can physically rewire the deep-seated, agonizing, maladaptive loops of severe treatment-resistant OCD, what other rigid cognitive patterns might simply be entrenched neural circuits waiting for the right catalyst?
Oh, wow. Think about the things we consider completely normal parts of our identity. Our stubborn personality traits, our deep-seated biases, our societal habits, our rigid ways of viewing the world.
Are they truly intrinsic to who we are?
Or are they just roundabouts that we've been circling for so long that we've totally forgotten how to take an exit? If the brain can physically sprout new branches to escape the gridlock of OCD, what could it do if we learned how to safely unlock that neuroplasticity for other entrenched ways of thinking?
If the diagnostic landscape of the mind looks murky, maybe it's because the structures aren't supposed to be set in stone to begin with. Maybe the mind is designed to be fluid, and we are finally developing the tools to unfreeze it.
That is a wild thought to end on. Thank you for joining us on this deep dive into the SpiralSeekr material. We hope it gave you as much to chew on as it gave us. Keep asking those big questions, keep challenging the baseline, and most importantly, stay insanely curious. We'll catch you on the next deep dive.